if you're like me, when you're going to go on a road trip, you sometimes pack a playlist, right? Who does that? Anybody bring a playlist when they're going on a road trip of your favorite songs? Or at least your favorite Pandora station is going to play the songs that you love? So as I was developing this summit theme, this thing got stuck in my head. So the playlist that I want you to think about as we're moving into the next session is Amy Winehouse, gonna make you go to rehab. Because we're gonna shake up your thoughts about rehab. Because many of you probably had no idea that there's such a thing as rehab with bladder cancer. And you might know about rehab or physical therapy after, say, knee replacement surgery, or perhaps occupational therapy after a work-related incident and you need to get back to work, something along those lines. But now's the time to learn about cancer rehabilitation. It, believe it or not, is a thing. It's a specialty area, and we have wonderful speakers here. I'm really delighted to welcome our cancer rehabilitation experts. It's going to be moderated with Dr. Jessica Engle from Johns Hopkins. And then we also have ReVital Cancer Rehabilitation occupational therapist, Kirsty Livingston. So she'll be speaking. And then also the director of education, who is a physical therapist, Alaina Newell, who came to us from Colorado. She came to our Phoenix Summit as well, are going to take over and talk to you for the next 90 minutes. We will save time at the end for Q&A. We have mics in the room, so when we get to the Q&A time, just raise your hand and we'll come around with the mics, or you can come up to the mic stands and we'll let you talk so that we can record everything that people are asking us questions, okay? Looking forward to it.
All right. Well, thank you very much for having us, and we're so happy to be here, and thank you all for coming here as well. And like Stephanie said, we're going to talk about cancer rehab. My name is Jessica Engle. I'm a physician with Johns Hopkins School of Medicine, and I see patients in the DC area as well as a suburb and up into Baltimore. And then I do a lot of virtual medicine as well. Okay. So. And then obviously, oops, sorry, we have Alaina here and Kirsty. So our agenda today is we're going to do a little bit of a brief introduction to cancer rehab. What is it exactly? Is it what Amy Winehouse was talking about? No. But confusingly enough, when I was in residency, that was the floor above us. So people got off at the wrong floor all the time. And then we're going to have a facilitated question and answer expert panel. And then we're going to have an open forum as well. So get your questions ready. Okay, so we know that bladder cancer impacts quality of life. So folks were asked, and the percentage of survivors that said they did not have any supportive needs was only 12%. But 88% of folks said they had at least one unmet need. And cancer rehabilitation is supposed to be, we try to be all-encompassing. I don't know that we always are, but we try to incorporate different parts of a person's life. We think about their physical functioning. Are they having trouble walking? Are they having trouble, for example, getting on and off a toilet seat? Are they having trouble with neuropathy, other issues? Their psychological health as well. Are they sleeping okay? Or are you ruminating over some of the things that are happening with your cancer? Function as well. You know, like I said, are you able to get on and off a toilet seat? Are you able to put on your shoes and socks? Any issues with your function? Social as well. Are you able to go out and have these meaningful connections with loved ones? Or are you able to facilitate that with other means? For example, using a virtual platform so that you could talk to a loved one in another state. And also vocational needs are very important as well. Is this affecting your range of motion? Is this affecting your endurance where you're having difficulty going back to work or doing things that you love? And also even some things as well, like hobbies, sometimes we have to think about as well, because that means a big difference for a lot of people. So the history of cancer rehab. So I technically am in one of the newer fields, physical medicine and rehab. It technically started in 1947. And there was some stuff that started beforehand, but in the 1940s, there's a really famous doctor, Dr. Howard Rusk, who first described cancer rehab. And then in the 60s, Lyndon Johnson was the president on the time, and he had commission on the cancer, heart, and disease and stroke. In the 60s and 70s, this propelled further, where MD Anderson was first employed PM&R docs, and that was Dr. Rusk, MD Anderson and Sloan Kettering, first employed PM&R physiatrists. We have like 3 names. So some people call us rehab, some people call us physiatrists, some people call us physical medicine and rehab. And they employed us, Dr. Rusk and Dr. Dietz. And Dr. Dietz wrote like the first textbook. I was sharing earlier, it's out of print, and I've been trying to get some of the out of print books. And it's very interesting to see their models. In 1989, AAPM&R, Cancer Rehab Special Interest Group, and AAPM&R is our big physical medicine and rehab group. We have a conference coming up this year in New Orleans, had their first special interest group, which is now the CRPC that I'm part of, and that started in 1989. And even when I went to a meeting in 2016, we fit in a room that was much smaller, that's half the size of this, and now we wouldn't even fit in this room. And then in 1990, MD Anderson started the cancer rehab program, or resumed the cancer rehab program. And in 2001, Sloan Kettering resumed their cancer rehab program. In 2007, MD Anderson had their first cancer rehab fellowship, and that was Dr. Arash Asher, who was one of my mentors, who was just absolutely phenomenal and does a lot of work on loneliness and many other aspects. Then I actually was a fellow quite a few years ago now as well at MD Anderson. And then in 2019, the APTA had the first certification in oncology. And there are different phases in cancer rehab that we look at. So there's the preventative phase. For example, we anticipate and lessen the effect of potential disabilities. So if we think that someone might be having an issue, we try to get there as soon as possible and prevent that from occurring. There is the restorative phase, or return to previous physical, psychosocial, and vocational functional status, where we're trying to get someone back to where they were. There's also the supportive phase, where we train to accommodate disabilities and minimize impact of disease. So we know, for example, that when someone's diagnosed with cancer, whether you're the strongest person on earth or the weakest person on earth, your function is going to decline. And so we train to accommodate for these disabilities and minimize the impact that they'll have. And we try to get people as strong as possible at the same time. And then there's also the palliative phase, where we work on symptom control, and we also try to prevent and minimize different complications and to provide comfort as well. And we know that cancer rehab actually improves cancer outcomes. And there's many benefits. It helps people, some of the biggest thing is it helps with fatigue, it helps with function, mobility, cognition, mood, social vulnerability. And part of that aspect is you're able to have maybe more energy to do things that you love, to join a virtual call to talk to someone, or to get out and be even part of a recreational activity like a bingo game or something with friends. We know that it helps prevent disease, helps prevent recurrence in some folks. You can't do, it doesn't 100% prevent disease, unfortunately, or 100% prevent recurrence, but it can prevent the occurrence or recurrence of certain cancers in some instances. And it helps people's nutrition, their energy, their function, mobility, and the list goes on and on and on. And what makes cancer rehab unique, you might ask? Well, we take into consideration each individual person, what you bring to the table, what you like, what you dislike. We're not going to make someone do, for example, something like a triathlon, if that's not your cup of tea. We're going to take into safety considerations. Does someone have a bone metastasis, and we have to be careful about how much weight we put on that side? Or does someone, for example, have is possibly going to get an ileostomy or something along those lines, where we have to take into consideration how much pressure you put in the abdomen. We look at rehab precautions. Does someone have, for example, spine precautions from a spinal cord injury that occurred years before? We try to screen for and address cancer and the treatment-related side effects. We look at each specific cancer, the treatments that you had, possibly the treatments that you're getting right now and maybe are going to have. And we take into consideration things like possible neuropathy, for example, fatigue, maybe a certain type of treatment you might be getting is very notorious for causing constipation. And how do we prevent those things? And then we take a holistic approach. There's no cookie cutter approach in these things, and it can't work. And I've been asked time and time again, what are the top 10 things you could do for this cancer? Well, it's going to be different for you, for you, for you, for me, and so we have to tailor it to each person. And we do this, and we look at it through this multifaceted lens. We incorporate all members of the team. We look at the physician, physical therapy, occupational therapy, speech therapy, pelvic floor therapy, a dietitian, integrative medicine, whatever that particular person needs. And we treat folks throughout the cancer continuum. We see folks that are perhaps diagnosed as previvors. For example, they might have inherited a BRCA gene or something along those lines, all the way through the entire continuum. When someone's newly diagnosed, when someone's receiving treatment, surgeries, radiation, trials, and even to the point of death, we'll see patients as well. And we will look at the bigger picture. We don't just look at, oh, your wrist hurts, so we're just going to look right here at the wrist. No, we look at the whole body. Well, does your wrist hurt because you're using your cane more, because your legs are weak? What is the whole thing that's going on? And so that's what we try to do in cancer rehab. And I think we have a few introductions, so we're going to go around. Okay. Let's start.
My name is Kirsty Livingston. I am an occupational therapist, a lymphedema specialist, and a cancer rehab specialist with ReVital Cancer Rehab in Nashville. We see patients at any point in their cancer diagnosis, from prehab to the end stage. I've been an occupational therapist about 25 years. I know you all thought I was only 21. Been doing it a long time. Everything that Jessica said is just resonating with me, because I think that's the core of what OT is, and it's the core of what cancer rehab is. So.
And I'm Alaina Newell. I'm a physical therapist, and I'm double board certified in oncological physical therapy as well as women's health or pelvic floor based physical therapy. When we were looking at the history of cancer rehab, it sometimes makes you feel young and old. I was one of those, when our board certifications that first year, I was able to sit for it, and over time, and actually on our specialty council from a physical therapy standpoint, to really ensure that we're elevating the care we provide, making sure what we're also doing is evidence-based, so we know it will work and they're the things that people will benefit from. Like Kirsty, I work with, as part of ReVital Cancer Rehab, as the Director of Education. So while we're here in Nashville today, ReVital, we're an organization that's throughout the country. So we will talk about it a little bit later of how do I find therapists like you or around your particular area? Because another piece that we try to do is really meet you where you're at. Figure out, coming into the different communities to ensure you get care, even if you're traveling to your cancer center to receive your medical treatments. Rehab, we try to kind of meet you in your environments. And just like Kirsty, I'm also certified as a Alaina lymphedema therapist. And so we'll definitely hit on some of that today as well.
Oh, and you know me, I started talking already. Yeah.
All right.
Do you want me to sit down?
Yeah. So we're going to start to transition to that portion where we do a little bit more of a Q&A so you guys can hear them a little bit more, dive into those different areas and how the three of us are different and unique from each other. A lot of times, like she had mentioned, that people know physical therapy, but how we work as a team, we want to make sure that gets approached. And it'd be ignorant of us to ignore those others that are on our cancer rehab care team and how we integrate with your greater oncology care team as well. So on here, you have us represented with Dr. Engle from our physical medicine and rehabilitation, and myself and Kirsty from the therapy aspects. But if you notice on here, there's other players too that might be part of cancer rehab, including nursing staff, people who work from a pain management aspect, psychology, surgeons, radiation oncology, medical oncology. We're all a greater team that's really looking at not just treating your cancer, but treating you as a person and getting back to what's important to you. So when we talk about this, you will hear us lean into some of those other colleagues and some of the services they may provide and then what our unique abilities are as well. So to start us off, Dr. Engle, would you mind kind of going in a little bit deeper for us of really what is the specialty of physical medicine and rehabilitation?
Sure. So I'm in physical medicine and rehab, and also known as physiatry or PM&R or rehab. And we're physicians that go through, high school, college, medical school, intern year, residency as physicians. And we don't necessarily look for a quote unquote cure. We usually try to make sure we optimize independence and to also maximize quality of life and help with what we call activities of daily living. And those are things where you probably explain it a lot better than I would, but things like bathing, dressing, eating, toileting, and things of that nature. And so we try to have this patient-centered, and we also incorporate the families as well, or the loved ones or the caregivers. And we design this comprehensive treatment approach. And we use integral members of the team, such as members of clergy, occupational, physical, speech therapy, different physicians, social work, and things of that nature. And we use cutting edge. We're always into doing research as well as time-tested treatments to get the best quality of life, to maximize function as much as possible for our patients.
And what are some of the interventions and techniques that are unique to you that us as therapists aren't able to provide?
So it depends on the person. My biggest thing that I try to do first is lifestyle is the biggest thing. And looking at someone's sleep, looking at someone's, for example, the times of day, maybe they're taking the medications can cause them issues, or the times of days of their treatments. And then we can also order different imaging studies if someone says they have pain, for example, in a certain area, or they are having limited range of motion in a certain area. Different things of that nature. We could also use, obviously referrals. Sometimes we'll refer to other specialists like acupuncture and maybe massage as well. Pool physical therapy is a big one we like as well. And we can also use medications. Because I'm a physician, I can prescribe medications if they're appropriate to someone. We can order labs to see, are you tired because maybe something else is at play here? Maybe is there an infection or your B12 level is low, and that's something that's easily treatable. And then sometimes we will do injections. For example, for pain, we can do things like a trigger point injection if someone, for example, is having a painful muscle or something along those lines. And if it's beyond our scope of practice, we know who to refer to, for example, if it's going to be an epidural or something like that. So.
And I love that you just kind of pointed out, potentially an injection. She pointed up to her neck. We talked about that holistic care we provide, and I think that's one of those key things. So when you're working with somebody on our team, don't think, oh, they're just worried about my bladder or my pelvis, but really, truly that head to toe. We're able to help manage that, because we also realize things come up during cancer treatments that maybe you thought you were done with because they happened 5, 10, 20, 50 years ago, and they've kind of crept back. So those are some of those things that we really love hearing about and have their tools to be able to help address those through your cancer treatment, or again, beyond. We'll hit more into.
Yeah, and I probably would also be remiss if I didn't discuss stress and the way we have our lives now. We're always on our phones like this, right? We're always, we're typing on our computers like this too. And when we get stressed out, we tend to carry it up in here. We tend to have this kind of posture, and those are all things that we can work on as well.
Yeah. You mentioned a little bit, but I'd love to go more into what are the other supportive care services and programs you offer? I know there's a number of these pieces. We kind of hit on this slide, so I'd love to know when you think about this, when you think about the supportive care, what does that mean or look like to you?
So I'm very lucky to be involved with several different networks in our area. But the other thing that has happened with one of the good things I would say that's come out of COVID is we realized it's very hard for people to get to a cancer care center. People are traveling from very far away. Let's open up a virtual option. And even if you're very introverted and that's not something you would normally do, is be part of a group activity, you can just close the computer if it's not for you, right? There's no risk at this. So we have things like yoga. There's a chair yoga, which is very low impact. You're doing it from your chair. There's a combination chair and mat yoga, and then there's a traditional mat yoga. There's also Reiki, there's art therapy, and these are just a little bit of the offerings that we do have. They're virtual, and Pam said it's okay if you contact her about some of these programs. And this is just an example of when they have them. Because there's so much more to life and to wellness than a pill, than a certain treatment, and we have to look at the whole person. So there's education series, there's support groups, for example, there's one with women in bladder cancer, there's another bladder cancer support group. Some of the things I couldn't put all on one slide, but also meditation and mindfulness. There's a nature program that's supposed to be great too, where people are basically, I think it's like forest bathing. And then there's quite a few things. So I'm happy to refer people to these programs. And there are other programs in our area as well where they have things that are virtual classes, and they put you with a buddy who's in a similar situation. And we have the talk and walks. There's similar things in the Baltimore region. But this allows people, if they're vacationing maybe with their grandchildren in another state, to continue to be part of this community and continue to have help from different avenues. And there's the art therapy class. People love the art therapy class. So that one was virtual, and they liked it so much that they then started getting together in person after the class was over, actually. So yeah, it's really, really helpful. And to have that other outlet and to try to, I don't think it necessarily needs to be a new normal. I think that this also can be an opportunity to learn other things, to try other things that you've wanted to do. So someone might say, I love your art when I was younger. I loved art when I was in high school and college, and then, life took hold. Well, maybe this is a chance to get back and have an expressive outlet with art therapy. Yeah.
So by all means, we'll make sure these slides are available if you didn't get these different contacts. With these, obviously, there's a lot of virtual options, and I'd encourage you to touch in with your oncologist. They may have some in-person offerings that are close to home for you as well, and then a whole number of virtual things are out there. So this space keeps continuing to grow. As we recognize, as we treat you, we also want to make sure you become you again, that full person back. And we know there's lots of components of ourselves. So please think about it, but also realize maybe it's the time to try something new. So you may have never done yoga before, and you're now worried about your balance. Okay, well, let's think of how can we start to progress into that space. Okay. Kirsty, can we touch on a little bit about occupational therapy? Oftentimes you may hear occupational and physical therapy, and we both work obviously a lot together, but also a lot of differences. So can you reflect on that?
I can. I think a lot of people, this is the non-OT answer is OTs do arms, PTs do legs. That is not the answer. That's the non-OT answer. And
Yeah.
if you're saying that, Jessica, I don't think you are.
No.
But I have heard people say that. That is not what OT is. OT is, I think, inherently everything we've just discussed. It is essentially looking at the whole person. And I remember when I went to OT school in 1991, and in my first year we did Reiki, yoga, all of the art, cooking as therapy. And I remember thinking, I studied pretty hard to go do this. But then, in addition to the other things that OTs can do, which is we can work in any area. So we can work in peds, we can work in adults. We don't come out with specialized skills. We come out and then we find where we want to end up. For me, this is cancer rehab because it uses everything an OT is. Because with cancer, we have cognitive impairments at times from treatments, we have fatigue, we have pain, we have neuropathy, and overall, we have a change in our function, which is whether it's the things we do understand, the activities of daily living, things like dressing, showering, bathing. Nobody likes for someone else to have to wipe their butt. I'll be upfront about that. And nobody really wants to talk about that. But when you meet an OT and we meet with you and we talk about, how are you sleeping? Is because if I do everything but someone's not sleeping, then I'm going to get in touch with the doctor and discuss that. That's great information. A lot of what we can do cognition. Which I think really does separate us a bit from PT, and we just slide between all the specialties. Instrumental activities of daily living are the things that we consider outside the house. And at the core of OT is meaningful activity. And it does not have to be paid occupation. It's what makes you, you.
Mm-hmm. Yeah, I'm really glad you clarified that because even as a physical therapist for the longest time, I don't think I truly knew what the word occupation meant.
Right.
So when I think occupation, I think, oh, that job I go to, right?
Right.
And some of you may have that. So really, let's hit on that one more time because occupation is way more than the job you're paid to go do.
I think most patients don't, when you say what makes you you, most people don't say their job.
Yeah.
They say their garden, their kids, their family, cooking the meal they care about, being able to go hiking without having a balance issue because of neuropathy or incontinence. Like very few people say, my job is me. So
Yeah. Kind of reflecting on that, when we think from a physical therapy standpoint, I think the one way to think about us is we're those movement specialists. So we really care about how your anatomy is, how your physiology, so how you move your body comes into play. This morning I was talking to a friend who's having some hip pain. I was like, you're questioning the movement specialist as to why you're having the pain? Like you're the data science guy. So think about us as we look at the body, how it moves, or how maybe it's not moving as well. And that's how we take our approach and go towards it. So oftentimes you may think of us for deconditioning or weakness, or you're not as strong or capable as you had been before. Balance problems is definitely a large one we work on, especially with bladder cancer survivors from some of the chemotherapy agents or radiation. Joint pains or range of motion limitations. Maybe you feel stiffer or you've been more sedentary than before, and getting back up, you have to get that re-stimulated. Neck pain, back pain, hip pain, shoulder pain, hand pain, you name it where it's pain, that's definitely an area we help try to reduce and help you get back to moving again. And then if we need to look to see if you need anything to help you move more efficiently or safe, whether in the short term or the long term. So really recognizing how are you walking, getting up and down from those chairs, getting on and off the floor, the toilet, in and out of bed are areas that we often kind of focus in on. But it always comes down to what's important to you. So that looks different from person to person, and we kind of have to divide out a little bit. When we introduced ourselves, both Kirsty and I talked about we're physical therapy specialists. Sorry, not physical therapy, lymphedema specialists. But would you mind expanding a little more on what lymphedema is and how that kind of relates to our bladder cancer survivors?
yeah. So I think firstly, people, a lot of understanding about lymphedema is people are not educated, and they've seen a picture of what lymphedema is, and it terrifies them. And often that is not a cancer-related lymphedema. So I want that out there. There are different types of lymphedema, so you can get it related to your cancer surgery or radiation when the lymph nodes in your body are impacted. The primary lymphedema is something that you were born with something and your lymphatic system struggled to keep up with the amount of fluid. I could go at length into the physiology of the lymphatic system. The next thing is, so when nodes are impaired, damaged, if you imagine it like an interstate, we've got too much traffic and it's starting to back up. So lymphedema therapy works on how do we manage that fluid and move it to another part of your body that is functioning, the lymphatic system's functioning better. And it's a combination of lymphatic drainage, skin care, risk reduction, and garments. And teaching you a big key thing, no one wants to hear it. Well, some people do. You've got to move, exercise, and people come in and they're exhausted and their leg or arm is swollen or their abdomen is swollen, their genitals, and part of managing it is moving.
Yeah. And when we kind of focus in on the oncology population, there's two major risk factors that we think and look towards it. One of those having lymph nodes removed, and it really depends on where those lymph nodes are removed, as well if somebody's had exposure to radiation, and again, depending on where that location is. So those can definitely increase somebody's lymphatic system from not functioning as well, and then develop into lymphedema, as we're seeing. Yeah. When we look at pelvic health or pelvic floor physical therapy, what we're really talking about is bowel function, bladder function, and sexual function. Sometimes that's symptoms of having, I gotta run to go to the bathroom because I have that urgency feeling, or you're going to the bathroom more often than you used to, or you're having difficulty getting it out or painful with it. Same with bladder dysfunction. not realizing you need to have a bowel movement, or it coming too fast or too frequently. Those are definitely areas we help with people throughout their cancer treatments and even post. So we definitely know a lot of these side effects can happen during treatment, but they may happen on later on too. So we kind of talked about that time spectrum we work on cancer rehab, realize the different time points that may occur. And then sexual dysfunction. We realize not everybody always talks about this, but it's an area that's important to us. We realize your sexual function and your intimacy is part of your activities of daily living. There are things that are important to all of us to really maintain those relationships and connections. So we're kind of those people that are going to ask you those questions, and we want to know more and help you work through that space of modifications or things we need to add in or thinking positioning. All that can be taken in consideration. When Dr. Engle and I were working on presenting this, pulling this talk together, one thing she brought up was like, we really got to hit on our rehab approach. Want to kind of elaborate what we think of like the marathon versus a sprint?
Yeah, so typically any time you see one of us, it's going to be a change that's going to occur over the course of several days, weeks, months, years. The rehab spectrum typically is not a one and done. And so we see folks at many different phases. So even if we're seeing you, for example, on this slide, at the pre-diagnosis time or preventative, or at the time of diagnosis, we're trying to prepare for what's down the line. Do you need to get stronger, for example, to get on and off a toilet by yourself? Or are you looking forward to going back? Something I've heard a lot recently is people wish they could go fly fishing, but are impaired by weakness, difficulty walking on uneven surfaces, and neuropathy, and the endurance as well involved. So it's going to be that this is not a one and done, that this is going to continue. And that might continue in different aspects. That might be that going to a subacute or acute rehab, for example, which is an inpatient stay after your surgery, and then doing outpatient down the line, but it's in different phases. So we see folks in the preventative phase, before pre-vivers or before diagnosis, at the time of diagnosis. During treatment, we still work on preventative aspects, restorative and supportive aspects. And at the completion of treatment, again, restorative and supportive. And we keep following up with these patients, and it might not be that we're seeing you as frequently as we once were. We want to have these check-ins, and sometimes people need a little bit of a check-in and a little bit of a tune-up as well. They might need to come back just for a little bit more lymphedema therapy. The garment might be reaching the end of its lifespan. These lymphedema garments don't last very long. The elastic is very finicky in them. And typically
6 months, they say.
Right, and it starts to kind of fray and roll down and not fit well. So we have and make sure you need the same size. So you might need these follow-ups. And we're there for preventative, restorative, and supportive rehab. And then even with folks at the end of life, supportive and palliative rehab, and brainstorming ideas that work for them. Does someone need, for example, to change the layout of a room to make it easier to get in and out of a chair to see their loved ones? We work on things like that.
Kirsty, how about you? Kind of same thought. When's the best time to see you?
At any time, honestly. And I was just thinking about all of those things. I don't ever think, oh, so you are purely, restorative. We're only restoring. Mm-hmm. We work through it. There might be one aspect of your function that we do need to compensate on, but another one we can fully restore. Mm-hmm. I see patients for prehab. So sometimes for lymphedema, some doctors want us to get baseline measurements because they know they're going to be taking out a lot of nodes. They're going to be radiating. Sometimes we do cognition baseline as well. Mm-hmm. Some surgeons I've worked with want to know if their treatment's impacting a patient's cognition. But overall, at any point in diagnosis, including, I did this for a friend recently who's getting towards the end, and we moved everything downstairs. We got, and full disclosure, the wife is a nurse. And the one thing she didn't get was a handheld urinal to sit beside his bed. And she said, and I've emptied it 15 times in an hour. So it's really, sometimes it's things you wouldn't think of, and sometimes it's really basic stuff. And it's just about a lot of listening to the person and what is important to them. Because like Jessica said, if you don't want to run a triathlon, then there's no point in trying to get there.
Right. Yeah, and it could be the smallest things that make such a big difference.
Right.
And one of the biggest things that I will talk to patients about is getting things like buildup for utensils,
Yes.
because then they say, well, now I can go out to eat again. I don't have to
Yes.
eat finger foods. And it's literally foam that you can buy on the internet or at
At
a
Home
store.
Depot, you can
Yeah.
buy the stuff you put on plumbing,
Yeah.
cheap.
Yeah.
Yeah.
And you can put it on anything. You can put it on a pencil. You can put it
Mm-hmm.
on a fork so you can go out to eat. I have a loved one that I was helping, and she put it on eyeliner.
Yep.
She's like, before we go out to eat, I need to get my makeup done now. I can put it on the
Right.
makeup brush. I can use the eyeliner because she had limited mobility of her hands from the location of her tumor and from neuropathy. And just little things like that can make such a big difference. Someone that has a tremor from their treatment getting a weight, a wrist weight, and they make these stylish ones now where you think it's a bracelet.
Correct.
You don't even know that it's a weight, and things like that can make a big difference. Can I ask to go back to
Totally.
the slide? Like, I think we skipped over it
Yeah.
about, I think I skipped over it.
That's fun.
This one, yeah.
Yep.
So these are some questions or some things I've just noticed of when we should be consulted, when cancer or its treatments have side effects that alter your quality of life. So for example, I might see patients that when I first met them, or I'm being told that they were extremely active, and now they have a new assistive device, and maybe it's a walking stick, maybe it's a cane, but all of a sudden they started using something, and I'm curious as to what changed that made you use this. Did you have a fall? And that's something I ask people about every day, and sometimes twice, just to double check. And they'll say, you already asked me. And I said, I know, but I'm just asking again to double check and make sure you're listening. Did someone come in originally with like a fold-up cane that was just peeking out of their purse or bag or something, but now I see them and they have a walker, or they're in one of those borrowed hospital wheelchairs. And why did they do that? Did they fall or did they nearly fall and sprain their ankle? Or are they really having a lot of new weakness? Do they have trouble, really walking around, don't have the endurance? Or they're not sleeping and they're so fatigued they just can't do anything? And these are all things we need to explore. And then does someone need additional care? Or maybe they were independent doing things before and now they need some help. And why is that? Or do they have a new caregiver? Did they need to hire a caregiver? And then also to these impairments that they have now, maybe they'll talk about how they love walking their dogs and they say, I can't walk my dogs anymore. Well, why is that? Do they not have the endurance? Are they afraid they're going to fall? What's the reason behind that, that they can't do this particular work or leisure activity? Another thing too is to see, is someone on new or an increased pain medication, and what is the reason for that? And could be so many different reasons. It could be a mass or a lesion or a new surgery, but is someone also having trouble really coping, and maybe they're coping with the pain medication. Maybe they have another issue going on that's left untreated. And then another big thing is impaired cognition, chemo brain, chemo fog. And we work a lot with occupational therapy. The other great thing that we found as a consequence of COVID actually is that we can do virtual speech therapy, which really helps people. So you don't have all that additional burden of getting ready for an appointment, driving through city traffic, parking, and things like that. You could just turn on the computer and you could do this virtual appointment, and that saves a lot of energy. And then we also are looking, we were talking about this earlier, what screening tools are the most valuable, but don't waste your time, that we can use to improve care? And that's an ongoing huge discussion. But these are all some reasons for seeing us, and we like to say the sooner the better. And then obviously if someone has new lymphedema or they feel heaviness in an area, swelling, trouble wearing something that they once were able to all of a sudden, that's an issue as well.
And please consult a lymphedema specialist instead of ordering anything you can find on Amazon. Because patients come in for their first appointment and dump, I bought this and this and this. That stuff is expensive and doesn't fit. And they're like, oh, my hand swelled up when I put it on. So that is a specialty. We do a lot of training to become lymphedema specialists. And just buying something, there's different levels of compression, different fits. Some people are allergic to silicone bands, so don't just go looking on Amazon.
And it could actually make things worse in certain
Correct.
cases because it could act like a tourniquet.
Correct.
So that could be an issue, yeah. So to help with all these different things. So, and I'm sure you guys have great advice for us as well as to what to include on this list.
Yeah.
You know, and as we look at that list, Ray, and we talked about screening tools, y'all are going to get the pleasure after us to hear from Dr. Smith. And he's really going to go through the value, the history, and the why behind things called patient-reported outcomes. I know everybody doesn't always love those. It's a page or a couple that are asking you questions. But really, we realized at the end of the day, we want to get to the heart of what's important to you and what's going on. And so I'm going to let him go way more into those, but it is becoming more and more important to everyone on your care team, really what's important to you. And those forms are just one way we're able to capture that. So you may get some of these asked during an interview with us, but we may ask you to put it on that paper too. And it helps us give us like a systematic way to checkpoint over time. How are things changing? Are we staying the same? Are we getting better? Are we getting worse? And going for there. So I'm sure Dr. Smith will keep elaborating that space for you.
And something else that I do when I see patients, especially new patients, and I'll ask them what their hobbies are, and they'll be like, "I'm sorry, did you just ask me what my hobbies are? What kind of doctor are you?" Or I'll ask them if they have pets, who they live with, who's their caregiver.
Yeah.
Are they working? Are they traveling? Because I'm in DC, so sometimes people are traveling hours and hours each day to work, and how are they dealing with that commute? Or sometimes you can work virtually and everything in between. But to try to just get to the heart of the matter and know what's important to them and what we have to try to work on as well.
Even as an OT, when I first meet a patient, I say that, like, what do you enjoy? Mm-hmm. What makes you you? And people just look at me like, what? Why? Why are you asking that? Rather than just me straight away going, move your arm, how much can you reach over your head? I try and always have a conversation. And I think as a care team, we have information that we can give to our medical partners. And it's just circular. We share the information. I was in a meeting yesterday with PMR, and that's what we were saying. Like, they can't afford their diabetes medication.
Yeah.
And that's a big deal. And they would never have figured that out. Little outside, but it's like a lot of conversation and knowing your patient.
Yeah. And then that's contributing to the neuropathy, which
Correct.
is a whole other issue. Yeah.
Correct.
And then also knowing what someone's goal is and working towards that goal. I had patients recently participate in an event that occurred in Baltimore. It was like a 10K, and working towards that goal. And what does that take and what does that look like? Yeah.
So I know we talked a lot about who we are, what we're doing. I'll forward our slides, but Dr. Engle, she's based in the DC, Baltimore area. Kirsty's here. I'm out in Colorado. How do we get a hold of us? How would one come see us or somebody like us? How do they find us?
So we are working, one of my colleagues is working on a cancer rehab map that has the different physicians that practice cancer rehab and where they're located. And I think she did it by where they did their training. So I don't know if that's.
I think it is. So
Yeah.
maybe we can clarify that a little bit. Based on who you see, our trainings all look a little bit different.
Yeah.
There's other doctors like Dr. Engle who specialize in physical medicine, but don't specialize in the cancer rehab part, working with cancer survivors. So when we look at that, they also go through training called a fellowship that focuses in cancer rehab. So this map just tells you where do they do that particular training, but the map shows you where they're currently located.
Right.
So you can see where the programs initially started were down in Texas and up in New York, and so there's more on those concentrations. Then as you move west, it's not quite distributed as some people started to jump towards the west side, but if you're living in this eastern part of the country, you can see there's a number that have started to be moving to most of the different major cities.
Yeah, we definitely need to expand more though. And we do have folks that are in Canada and folks that are in Puerto Rico as well. And so you can basically just search for a physical. We don't have a great website yet, honestly, is the real answer. But and I am not tech savvy, so I will have to ask some of the younger generation to work on this at our upcoming meeting. But it's definitely like I'm in, and then the other option is that some of us have a lot of virtual options as well, virtual licenses. So there are folks, in various areas, but you can look for cancer rehabilitation and you can ask your and honestly, sometimes all oncologists don't know about it, but talking to the navigators, talking to social work and folks like that, they tend to know. And also even working with physical and occupational therapy, you tend to know who your physical medicine and rehab champions are. And I'm also really lucky to work with, the ReVital is nationwide. So even if someone says, hey, look, I really want to go to Florida this summer or wherever else to spend time with my grandkids, where can I go to therapy there? Where am I going to find cancer rehab? You guys are a great option.
Yeah. Kind of as you said that, from a therapy standpoint, and some of our specialists, as physical therapy, our website, the American Physical Therapy Association, or APTA, you can find a therapist by specialists, and that'll connect you with all the board specialists. But there are a number of therapists who are not quite to that board level, but have been practicing in cancer rehab. So if you're going to see a physical therapist or occupational therapist, really ask them, what background do you have in cancer and cancer rehab? Because it's still not the same depending on where you're at and what schooling they've gone through. A lot of this has to be after we've graduated our professional programs, we've gone back to learn more about cancer rehab. So that's something I want to make sure you distinguish. Don't just go to every physical therapist. You want to have somebody who understands what you have gone through so they can best support and match what the care needs you have. And then there's a couple of other organizations. We had mentioned us at ReVital. We are nation-based. So on there, you can also connect us, and we can connect you if there's therapists closest to your area, as well as there's another organization called PORI, and they also have a Find a Therapist, and they're one of the larger cancer rehab training groups that are out there. And all these will give you, our site as well as Find a Therapist from PORI will give you for occupational, speech, and physical therapy. So it'll give you the variations, the different types of providers that you may need to connect with. Do you want to kind of talk about from a lymphedema standpoint where people can find us?
Well, lymphedema is a hard one. And I know this because one of the PMR docs I work with at Vanderbilt, and just for record, Vanderbilt's pretty well known. They've had an oncology PMR doctor for 3 years. She's their first. She was with Dr. Stubblefield, but Vanderbilt's, well-known, research-based, and that was their first PMR, oncology focused. They just did research study. Finding a lymphedema specialist is not easy. You can use CLT LANA, that means they've completed the exam, or the National Lymphedema Network. But finding a lymphedema specialist you may end up on a wait list. And I'm just going to tell people that, especially in Nashville. ReVital is not, but many places, because of the intensity of treatment and cancer related, often I don't think they separate lymphedema at lymphedema clinics. So you're in there with primary lymphedema and cancer related. In Nashville, ReVital just does cancer related lymphedema. So not as easy, but again, Google is your friend.
Yeah, I think so. All right, we're going to ask the question that we get asked all the time, so we'll just make sure we clarify it out. Are we covered by insurance? Yes. So all of our services are covered under typical medical insurance. So if you're wondering, can I see them or not from an insurance perspective, we bill the same kind of codes you would if you had a knee injury or you had a cold. Mm-hmm. We still bill those same codes. So do know that we are covered by insurance. We're about to kind of open up the floor here, but before we do that, I want to let them, any last things you'd either like to hear from our survivors out in the audience or caregivers, or anything else you want them to know about you, Dr. Engle?
That we're here, no matter what, and we're happy to help. And maybe if just because a specialist didn't ask you about something in particular, for example, you're really fatigued or you're not sleeping well, or you're not eating well, or you're really worried about something, we're here to help. We're not just we're looking at one body part. We like to work on all aspects, and ideally we see people as soon as possible and can get the prehabilitation down, get people as strong as possible before their treatment and surgery. And it's just very rewarding working with this population. We also do have to keep in mind that there are precautions, though, that we don't want to do things like, especially if someone's having a big surgery and going to have ostomies afterwards. We want to make sure you're not holding your breath and which is something we all do, right? We get, oh no, we hold our breath, right? Or we get nervous about something, we hold our breath. But that's something you have to kind of breathe through when you're doing therapy, so you don't increase what's called the intra-abdominal pressure and have a higher chance of a hernia, actually. So that is a big precaution, and something that just, affects us in our everyday life. Even if you're carrying a box and something scares you or something like that, you want to try to say, okay, breathe through this, and have that kind of ingrained in your mind. And to look out for things like, neuropathy, difficulty with balance, doing things that you once loved, and why can't you do that? And what can we do to get you back to that? Yeah.
How about you, Kirsty?
I would say the early thing is very important, and that it's not, you might have done therapy for a knee and gone 3 times a week for a month, and you think, I could not go to a clinic 3 times a week. Very rarely in the cancer rehab world does it look like that. Again, part of seeing a cancer rehab specialist is we understand that and we work around it. So the first thing I say is, when's your treatment? Okay, we'll see you before radiation or the day before chemo, not the day after. And that's one thing. So, and we really are here, doctors and your medical oncologists save your life, but I think we're here to save your quality of life. And that's our specialty. So I think sometimes cancer patients or survivors are just grateful. I'm alive, but then they're like, oh no, I can't sleep and I'm in pain and I can't pick up my grandkids. Well, that's real important stuff to me. And it really is an honor to work on that. And it's really powerful for both sides of that equation.
Yeah, you kind of lead into one of my favorite thoughts for us is, we don't want you to just survive. We want you to actually thrive. And we're really the people who try to make that happen for you. It's our end goal. And how you thrive is unique to you. So don't feel like you need to be like your neighbor, but let's figure out what's important to you. And that's what we actually want to work on. You said it's an extremely rewarding population to work in. I've worked in a number of different populations over time, and at the end of the day, people asked, why cancer rehab? Isn't that hard? I go, no, because the people I get to work with are some of the coolest people out there. It's true.
Yeah.
I like people out there. That's really, you guys are some of the coolest people, and you also bring us so many different thoughts for us to learn on a daily basis. And I think that's pretty unique when you work in the rehab world, to learn from you as much as we're able to. Okay.
So I think you're sensing a theme here. Survive, thrive. They should go together. We've been talking about that already. But, I was going to say this in my next talk, but you saved my life, but why? You took away some of the best parts. And there are teams of people who can help get those good parts back. So I think, are you guys done?
Darn close. We're about to open up for Q&A.
I was going to say, we're going to get the mics out because I really want to be able to hear the questions. So we're going to be ready with mics. So
We'll snag the mics. Before we do that, we know y'all, right? You started, we all had lunch. I'm sure that the tummy muscles are doing their thing and working, which is great, but it also makes those eyes a little sleepy. So before we open up the floor, let's all do, I like to call them movement breaks, right? We've been sitting for 45 minutes-ish. It's up to you. If you want to stay seated, you can. If you want, go ahead and stand up with me. Either way is fine. It won't impact what we're doing. I threw this slide up here because and you're going to get more on this tomorrow, of really understanding exercise as medicine. And Dr. Engle really commented on understanding what is happening through here, right? Understanding what's happening to our belly, your pelvis has been infected, and go, So what I want you to go ahead and do is just, however you are, go ahead and just take a breath. Breathe however you want. There's no right answer. There's no wrong answer right now. Just take a breath and feel that air go in and let it go. Okay, and we're going to do the same idea, but this time what I want you to do is go ahead and take those arms and reach up as you breathe in and let it go. You might find your neighbor, say hi with some little arm contact there. Let's do that again. You go up, take a big breath in, maybe reach back just a tiny bit. Whew, and bring it forward. Good. And just let those arms go. Feel what it's like, okay? Take a moment and figure out, where did you feel that in your body? You know, is it just in your nose because it's all clogged? Did your belly give you some grumbles? Maybe you felt it in your feet, right? As we reached up, maybe that balance was going back and forth and finding the ground. And so on this next one, I want you to think, can I take that air in? Let that belly stretch and expand. Bring that air all the way down into your pelvis, okay? Arms up if you want to, but you don't have to. Just take a big breath in. Breathe, make that belly expand out. Feel it down into your pelvis. Whoo, and let it go. Pull those belly muscles in just a little bit for me. Let's try that again. Belly up, let her stretch, and let her go, okay? So our abdomen and our pelvis do a lot of work to help us regulate pressure. After bladder surgeries and radiations, you may feel not as connected to there. Those belly muscles may not be working the same, but it's really important to be conscious of, am I holding everything in tight all the time? Or am I letting things go and letting those muscles rework, okay? So what I challenge y'all on throughout your day, give yourself just a couple minutes, take some breaths, reconnect, check in. Am I holding that breath, especially as I sit to stand? Am I on the toilet? Am I carrying things? Keep breathing through it. Use that belly and expand and come back down. Okay? All right. I think we're ready for those mics.
So if you have questions, raise your hand and we will come around with microphones so that everybody can hear you.
Can I just add two things I forgot to say?
Yeah.
One is that, speaking of the VA earlier, a lot of people have VA benefits and don't actually use them.
Oh, yeah.
And so there are a lot of great programs that the VA has, and programs could be free assistive devices for those who qualify, and whether that be a cane or a walker or something like that. I've even helped people when I was in training get chairs to go into on the sand and the beach. Also, they have programs as well for people that need things like stair lifts, people that need things like modifications. Maybe they only have one bathroom in their house and they can't get through the door with a walker, and they can help sometimes with modifications there. And so it's really important to access those benefits and to get connected as well, because people are entitled to them. That's important. The other group that I didn't mention, and I feel terrible about it, is our extremely esteemed colleagues in wound care and ostomy. And they're fabulous, and we work with them all the time, and they are the MacGyvers of the world.
Good word.
And we definitely work very careful with them, and there's a lot of emails and phone calls, but they're a great resource that we have as well. Yeah.
Okay, so we have our first question over on the left side here.
Hi, that's loud. I just have two questions actually. One is I saw on your map that you have you have actually two locations in Canada, one in Calgary, one in Winnipeg. Any further west towards Vancouver on the west coast, or anything coming?
So this
contacts?
this is not ReVital. This is where we have some of the cancer rehab docs. I would have to check with some of them and get back to you. I don't know about those locations specifically.
Okay, and then the second question was, this is a great map for rehab facilities facilitation. But is it specific to lymphedema or just?
These are just physicians, and it's not even all encompassing. It's just it's in the early stages, and I think something we're going to bring up again at our conference in around the 15th or so in New Orleans, because we want to make it available to the public, and that there's a hyperlink to get connected.
The 15th of this month?
Yeah, we're supposed to talk, and I don't know how quickly it's going to go, but it's supposed to be. We're supposed to talk about it this month, because it's really important to be able to get our services out there. And I think that they are going to try to, and there is some of the physicians are on what's called the American Congress of Rehab Medicine, but you have to add that to your profile.
Okay,
And so I don't think everyone's done that.
So there may be more rehab centers further west that you
Yeah,
just
definitely.
You just haven't connected to.
Yeah, and those are just the physicians. So there's still physical, occupational, speech therapy that are very likely further west. I don't know if ReVital has any.
ReVital, we're not in Canada. We're just US based, but the Seattle area, we do have our therapists are based out of there. To find the therapist that's closest to you, I would recommend going to these websites. The APTA website has it. They do Canada also does have their own physical therapy association website that has where the therapists are at. PORI, as well as they'll find a CLT through LANA. Those are international based. And so I would check their websites. That'll be the best. What they have you do is put in your city and state or your area codes, and they'll pull up where's the closest person for you.
I'm sorry, on what page, what site is that?
On this site, if you look on here, the third one down on Cancer Rehab Specialists, that one's international. And the first one on lymphedema therapists, that one's also an international based.
Thank you.
Yeah.
Yeah, and there are a couple docs as well that are but they're in Seattle that I know for sure that specialize in cancer rehab. At least two, maybe.
Yeah.
I don't know if David's retired.
I'm not sure.
Yeah, so at least two, they're in Seattle.
Yeah.
So any other questions? Questions over here? Thank you for using the microphone. I appreciate it.
Brian, do we need a referral? Can we do it ourselves? How does one avail of oneself?
Great question. It depends on which one of us you're seeing, and I will say a little bit to your insurance sometimes. So some insurances require that primary care to send to any other specialist. And then it also depends on our discipline a little bit. So for physical therapists in most locations through the country, you can direct refer yourself to see us. But we like to know what's been going on from your cancer treatment side. So we really do like to be connected at least with your medical oncology team so they can help us understand what's your history. But physical therapy you can. Unfortunately, occupational therapy does require a prescription wherever you are in the country. And Dr. Engle, am correct in terms that it just depends a little more on insurance if they have to have
It
a
usually
referral?
depends, yeah, more on insurance, whether or not they have a referral. Ideally, we have a referral, but not everyone has a referral. But some insurances do require that you have a referral depending on how your insurance is, yeah. But I do see patients all the time that like found me on the internet, so.
And we can usually coordinate too sometimes if we need to with you to connect with those physicians.
Yeah.
Exactly. So if you get a hold of us, we can be like, okay, who's your oncologist?
Right.
We can help do some of that coordination as well.
Yeah.
Yeah.
Hi, I'm Karen Sachs, and I'm a bladder cancer survivor, but I'm also a nurse navigator. So I talk to lots of patients in different parts and different stages of their journey. If I can speak with them before their surgery, I really like to try to refer them to your specialty to get them ready for surgery. I guess one question I have is kind of, what's the ideal time period? And the other thing is, how do you find someone that knows about a cystectomy? That is one thing that I'm finding that's very difficult. I'll send patients to a physical therapy center and they'll say to me, well, it was kind of a waste of my time because they didn't know anything about what I was going through.
Yeah, no, that's a fabulous question. I pulled this back up to kind of just reiterate when's the best time? The best time is as soon as you know you have cancer, realistically, so that way we can understand where are you today? Do we need to optimize you? Meaning, do we need to help actually build up your strength and your function before you go in? Because one of my favorite slides here is, we know we will all have an impact to our function when you have a stressor in life. Those stressors can vary, right? It could be an illness. Maybe you got pneumonia. We all feel sick. We all kind of come down our functional status. And then ideally, we all kind of rebound. We recover back up. So depending on how high you are on that functional capacity here, really tells us a thing we call are you robust or frail, meaning has your body been weakened in that kind of cyclical state that it's harder for you to bounce back over time. And so we like to see you as early as possible so we can pull that recovery back up to where you were. If we see you earlier on, the chances of taking that hole and shifting it upward is better, right? So we can make sure that function is as best as we can. But we realize that may not be plausible, especially for some of y'all in the room. You may be past that stage. And so really then the best time to come in is as soon as you can. So can we get you as time goes? Because we want to make sure each time you have a new stressor through your cancer journey or other things that happen in life, we can help build you back up, okay? With that, our goal is to make sure we keep you as robust as possible because we know you'll be able to tackle what's next better. Maybe it's continuing on a cancer treatment or doing a road trip, right? What's that next big thing that's going to happen in life? When you the question to address, like, how do I find somebody who knows what, the different surgeries are and what radiation does? That's where it really comes down to coming and finding out what they know about cancer rehab. I'm going to kind of go back to this map, this page of looking for those cancer rehab specialists are out there. We're growing. We really like, we're putting out an article soon. Still, there's probably only about 5,000 of us in the country. And that's just saying they have any cancer rehab knowledge, not necessarily always at the specialist level. And so that's where I'd really encourage you to go to the people who have taken that time to go deeper into cancer rehab versus just potentially your therapist that's down the block is going to give them that extra knowledge. Unfortunately, when we're working on it, it's just still not enough of what people get in their initial schooling for rehabilitation. Cancer rehab's not quite that high enough level yet.
Well, thanks for this. Actually, I wish I knew all this last year. But anyway, the thing that surprised me was after surgery and even prior to, this was not even on the radar.
Right.
And I know you're saying you're fairly new, but how do we educate my wonderful surgeon, and I'm sure there's a lot of them out there, how do we educate them? I mean, I feel like I was the navigator. I was saying, this is what I need, this is what I need. Yeah, that sounds good, you should do that. Okay, but I just want to.
Yeah.
I just want to know if I had walked in, first of all, you're dealing with something that you've never dealt with, and you're like, woo. So I just want to know if there's ways that we can, move forward and let these physicians and these surgeons, these wonderful people, know that this is something that they need to touch on, and that's what I'm wondering. Is there something going on in the background right now?
So do you want to take that one?
So I think we were talking about this last night, that most of what we know, we did whatever, residency and fellowship in school and everything, but most of what we know we've learned from all of you. I'll say that first of all, and thank you. And the more time we practice, and we are having evidence-based medicine as well, but we've learned a lot from all of you. And I think part of it is, like I said, we don't have a good map. I'm a rehab doc, and we don't have a good map. We need to do better as physicians. We need to demand that this is done, and that this is something that's offered. I mean, someone has a spinal cord injury, of course they're going to see a physiatrist. Like, it's like part of the package. But if someone has cancer, that's not something that's always part of the package. And so that's something that we need to do better. We need to advertise better, I think. And we need to make sure that these services are available to all of you and people that will be at future meetings.
And I'm just going to add a little beacon spin to this because we're on a theme here for 1 second. Then we're going to go back to questions because we still have plenty of time. I just want to let you know that one of the people that we supported as a young investigator, we gave them a $50,000 grant a few years ago, is a woman named Dr. Sarah Sutka. She's a urologist in Seattle, Washington. She works with one of Dr. Engle's colleagues, Dr. Hannah O, and they did some work on this idea of prehabilitation and rehabilitation prior to cystectomy. And I'm really delighted to say that we just gave Dr. Sarah Sutka $1.5 million. This was money that was donated to Beacon to fund a clinical trial to go to that next level. That trial is open and they're working on doing a lot more of this. And they will present that data at our scientific meeting. That is one way to get it to a lot of the people. And it may take a while, but that trickle-down effect is really going to happen. The change is happening, and I'm really thrilled to say that Beacon is funding a lot of that change. And you know, as you guys get your map done, let us know, because we'll be able to link to this. And I also think, is Mark Story in the room, or is he in interview right now? This is a good podcast down the road, especially as they had those maps developed after their meeting and things along those lines. So you'll hear more about it. And I know we'll go back to questions. There was a question right there.
Yeah, hi. You know, as you're talking, we're all learning an awful lot. I was just wondering, since we have 80,000 people a year getting bladder cancer, you have 5,000 specialists, I wonder, is there any opportunity to do some of this virtually? I mean, where people can communicate directly from their homes and learn of what we are learning today about their situation.
Yeah, absolutely. ReVital, we host, and actually Kirsty is our host of it. We have a webinar series called Living Well Beyond Cancer, whereas we really, and they're available on YouTube. If you search up Living Well Beyond Cancer, of the different areas, we kind of dive in a little bit deeper of how we help with different parts of the cancer journey. And our organization, that's one of the reasons I feel very privileged of being here today, is we're trying to do a lot more advocacy work of getting to all the different people that are important. And so I get this great opportunity talking to y'all today. One of my colleagues is at ASCO, which is a big oncology conference, talking about quality and how prehab makes a difference on the quality of people's lives and their care throughout it. So I think, you know, continue your advocacy work. You guys are very powerful. I know a number of us work in that space as well to try to keep elevating it. And the virtual is, we realize that that's how we have to connect a lot of it, unfortunately, right? To get that message out stronger and wider. So using those different avenues and using your voices really makes a difference. And we're trying to do the same. It's just like you said, it's these small engines, we're getting better. We're getting more steam as we go. And it's shifting, right? I don't have to quite explain it every time as I used to, but it's one of those, keep pushing for it. Keep, you know, emphasizing your function, your quality is equally as important to you.
I think as well, patient-reported outcomes are becoming more and more important, and that will push those that are a little more medically aligned and not looking at the big picture to look when the patient's like, you know, no, my quality of life's not great. No, I can't do what I want. Yes, my mood is low. Then there is going to be an ask that people do something about that. But research, you know, less than 2% if you take lymphedema out of patients that have an impairment from cancer are sent to therapy. So we've got a long way to go. It's not just you. Like, we are out here banging on any door we can get in.
Yeah.
But as a profession, we're just sort of newer and really out there trying to push it. And I think oncologists are really trying to save lives. And we're trying to find where we meet.
Yeah. And
Saving quality of life, yeah.
And lots, yeah.
Yeah,
yeah.
agreed.
And I think to some end, I don't want to toot my own horn, but we can make the lives better of the oncologists too, because we're making the patient's lives
Correct.
better. And so that hopefully then the patient is able to tolerate, well, we know the patient's able to tolerate treatment better. They're not getting as many messages about different symptoms that we're trying to help prevent and help manage as well. And the other thing that's great about virtual medicine is that you can see into someone's house. And you could see, I've had patients that say, I'm fine, I'm fine, I'm fine. And then you do the virtual visit and you say, oh my goodness, this person has, you know, trip hazards here, and this could be optimized a little bit better. So I think there's a big value in the virtual appointments. And we also sometimes will catch things that will prevent patients from being hospitalized. We'll have a virtual visit, and then we'll be able to catch things, and maybe they can just come into the infusion center and have, you know, their electrolytes repleted and have IV fluids, as opposed to falling and having an emergency room visit.
And, you know, these are all such wonderful ideas, and with your feedback as well, look for potentially a webinar specifically with the folks on those teams that are bladder cancer specific in the spring. That is very possible. So we're working on our schedule. We've got a few things already planned coming up for the next couple of months, but this spring it would be a good time, because a webinar is something that can reach anybody, anywhere, all the way to Canada and beyond. So, you know, there's lots of good options there. What other questions?
I have a question. It's about lymphedema, and it's
Can you speak into the mic a little bit louder?
it's mostly caused by cancer treatments and removal of lymph node. If somebody has a lot of lymph nodes removed due to cancer surgery, let's say like 10 years ago, at 47, should I be concerned about?
Yeah, well,
Because
great question.
I mean, now sometimes like my feet are swelling or whatever, and people used to look at my feet and said, "Wow, cute shoes." Now they said, "Oh, your feet are swollen."
Okay. Yeah, I think you kind of just answered the question a little bit for us. When we look at lymphedema throughout the world, cancer is the second most common cause because there's a parasite that causes more in other countries. In the U.S., cancer is the leading cause of lymphedema in the U.S. Cancer treatments, I should really say. And so when we look at that, I had said that removing lymph nodes and having radiation are those two major cancer-related treatment effects. Other things like lifestyle, sedentary, higher BMIs, more weight, as well as if you've ever had injuries or infections play into that picture as well. There are many people out there who will have those treatments and never develop lymphedema. But we do know a portion will. And so what we want to do is screen, meaning asking you that question. Do you ever have any heaviness, achiness, fullness, swelling? Think of your belly button to your feet. And if you're saying yes to those questions, it's worth getting a screen to figure out, is that swelling from another condition, or are you having early signs of lymphedema? The earlier you're diagnosed and the earlier we start treatment, the less involved it is, the less it impacts your life and lifestyle. And so if you're saying yes to those questions, I would consider meeting with a therapist to be able to further investigate what that presentation is for you.
Once lymphedema, once you've had lymph nodes removed or radiated, and I believe it's more than 8 is one of the numbers they look at, but once you have it, it is a lifetime risk. It's just the first 3 years we tend to think higher risk, but things can change. You could fall and break an ankle, and then suddenly you're like, whoa, what happened to my foot? So they're sort of how we look at lymphedema.
Hi. This is a question for Andrea. You mentioned the doctor in Seattle, Sarah
Sutka.
Sutka. How do you spell that?
P-S-U-T-K-A.
P-S-U-T-K-A?
Yes.
And is there does she do virtual support as well?
I imagine that she could. So she is available at the University of Washington and Fred Hutch Cancer Center in Seattle, Washington.
University of Washington and
Yep.
Fred Hutch Cancer Center. Thank you.
Yep. Another question over here.
I,
Oh.
My wife's 2.5 years after she started experiencing lymphedema. You touched on something about buying stuff from Amazon and not
Are you
fitting.
guilty?
And now, do y'all have a network or an information center on where you can buy stuff?
Yeah, so that's what your lymphedema specialist would do. We guide you. I mean, depends where you are. We work with DMEs. You usually need an order. It's not always covered. There's a lot of things that your lymphedema therapist knows. They have relationships with your rep in the area, all of this stuff. But it's not something, because it's like when we say we measure someone, we reduce volume of fluid if we can before we get a garment. So I couldn't just say, go to Amazon and buy this brand.
Yeah.
It is a fitted garment that is like getting, fitted for a custom wheelchair. It is a very specific garment.
Yeah.
So, Kirsty, a DME you mentioned, is it direct medical equipment or something?
Yes.
Is that what it is?
durable.
So, durable, okay,
Yeah.
yeah, durable medical equipment. So it's those medical equipment places that are there in your neighborhood, so it would help to get
Yeah.
a prescription for what you need, so that you get the right things,
Yep.
so that you're not
And
gonna
it
cause
just
more harm.
depends, because in Nashville we have a one called Pretty in Pink that was more focused on breast cancer, but it has all of the compression.
They could be pretty in orange.
They can be pretty in camo, and it comes in whatever color you want. But they would prefer a lymphedema specialist fitted the patient and then sent the order over from the doctor, then them walking in. Some of them, I'm unsure where you live, but you might have someone that has a specialist fitter at that place. It's very location specific.
Yeah.
It's a health desert. Well, you're someone we would look online for.
Yeah.
Yeah.
And also sometimes we have to do certain things where someone needs like a custom garment. Even.
Correct.
Yeah.
But I have a patient, for example, that has a custom garment, but they love to go running, and if they go running in the custom garment, that's going to be wet.
Yeah.
So they'll switch into something just to run, or they'll use an older custom garment just to run, and then they'll take a shower, get dried off, and put back their custom garment. So everything is tailored to each individual patient.
Yeah.
So if you're in a circumstance like that, that's when you'd work with a lymphedema specialist.
Yeah. There are online DMEs as well, but it comes to the same problem of making sure, are you getting the right product for you at the right time? So you can order from online, but the key is having that connection. And each DME does vary of whether it's a therapist they want to fit, if they have their own fitters. Unfortunately, it's kind of a hot mess in that space. And so just realize that's why it's like, hey, connecting with some of these guys will just help you out in that area. I kind of failed to mention, before this I was on a call, if you're all familiar and you are having symptoms of lymphedema, last year there was a really important piece of legislation that went through that was 13 years in the making, called the Lymphedema Treatment Act. Prior to this, Medicare had not covered compression services, and they are now. Starting January 1st.
Yeah, January 1st.
It's not quite yet, I would say now, in a couple months, soon. And some of the details are still not fully worked out. That was the advocacy call I was on. So just know, come January 1st, they'll be covered. It will be still a little messy, I'm pretty sure, until the first year is where things are looking. But do you know if that's something you've experienced in the past after January Medicare will cover? We don't know how other private insurances will take on that quite yet. We hope that they do follow along with Medicare over the next year or so and start to be on. So just recognize, we know historically that's been really hard, but that should start to be improving as we move into 24.
Yeah, and I predict, traditionally, this is a weird thing that happens in lymphedema treatment, is that folks realize they do have more benefits left for treatment towards the end of the year.
Yeah.
And it gets cooler, so your business, the numbers are probably starting to get picked up.
Yeah.
And then also come January 1, now we have this new bill where
It's gonna be a little crazy.
it's going to get a little crazy. So I would try to get in sooner rather than later, because then also January 1, some people will have benefits again, and they will literally try to go to therapy starting on January 2nd.
I mean, I have patients who are literally waiting for January 1st. So, like, put me on that list. As a specialist, we try real hard. If I can get someone in a non-custom garment that costs less with insurance not covering, that is my first priority. But I also have to educate patients on the difference between those and how much compression you need. And I have helped patients find non-profits that will pay for garments. Lymphedema, I think you called the wound care nurses MacGyvers, but lymphedema specialists are pretty good at figuring that stuff out too.
Yeah.
Hi, right here.
Hi.
Right, yeah. With regard to DME, I already deal with a DME company. Well, I probably dealt now with about a half a dozen because I fired the first 5.
Yeah.
And my experience is with regard to CPAP. And I was warned by my then doctor to be very, very careful who I chose. And I know that there's a somewhat of a movement, particularly with regard to CPAP, of getting this dealt with more through the physician's office than it is by contacting a DME, because some of them are just horrific.
And I think a lymphedema specialist, that's what we know. So, I mean, that's a lot of what we do. I emailed Pretty in Pink last night for a patient because they told me they've called them twice. They've moved offices, the number was wrong, it was a miscommunication, but the director like emailed straight back. And I think that's where knowing your doctor or therapist in your area, we do it every day.
So intervening.
Yeah.
On my
Yeah,
behalf,
and
so
just
to
telling you, I wouldn't use that one, I would use this one, or,
Yeah.
you
That's why
know.
I've had 5.
Yeah,
pretty
exactly,
much.
exactly.
The other thing that I wanted to mention was toward the end of my professional life, I took a position with a U.S. congressman, just helping people helping people get their passports, et cetera, et cetera. I recommend to everybody in this room that if you're not getting anywhere, contact your local congressperson. They want your vote. They will go out of their way for your 1 or 2 votes. I know it's a little bit off the topic, but my local congressman knows me very well now. And thank you.
Welcome.
Just to add to that, you know, when you reach out to your representatives, either at the state level or the federal level, when you have a concern that's not being met in your community, you're speaking for all the patients in your community. So you are advocating on behalf of the bladder cancer community. And, you know, periodically we do ask you, hey, reach out to your representative. We think this is important. And when we do, we'd love for you to be able to do that. And when we do, we try to send you a way to make it really easy. It's a quick email. But, you know, when we do send out alerts for stuff that happens, please help us out too, because we're advocating for everybody. But the issues that you bring forward, when they go to your representatives, next time we go, they think, oh yeah, I already know a little bit about bladder cancer because one of my people told me about it. So, you know, it helps. It really makes a big difference.
Okay, hope this works. Yeah. Couple simple questions on your map, if you wouldn't mind bringing that back.
Yeah.
Down in Arizona, that little small state down there on the left, it's got San Diego by the only dot I see in Arizona. That's not San Diego.
Yeah, Dr. Sarah Park, she is based primarily out of Tucson.
Tucson.
But she does do Phoenix some of the time, but her primary location's in Tucson.
So that is Tucson. Okay.
Correct,
cool
yep.
with that.
I know, it's funny how big San Diego is right there, but you're right.
Didn't look like San Diego
Yeah.
where I'm from. Anyway, other than that, the other thing I was wondering, I have neuropathy really bad in my feet and my fingers. I have not had anything removed or anything like that. I did finish my chemo treatments September 1st. They didn't work. Well, another story. Is there anybody in the room that would be willing to talk to me about neuropathy?
Oh, you know, we did not hit a whole lot on neuropathy today, you're right. That is definitely an area we all work on pretty regularly. It's probably one of the most common reasons we actually see patients. And how you described it was perfect. We know oftentimes chemotherapy-induced peripheral neuropathy, meaning that numbness, tingling for most people, sometimes it's pain or lack of sensation. Often we call it the stocking glove, so it's usually bilateral. It's going to start on the fingertips. It can work up its way at the hands. Same thing with the feet and the toes and work upward. There's a number of different things we can do. Can we make it 100% go away? No, but can we help you as your body is recovering out of chemotherapy and rework and refunction with it? Yes. And we all have slightly different approaches based on, you know, what piece of it we're working with. So it's definitely something I think we take a team approach when it comes to neuropathy, but usually we're the ones who are going to help you manage with it.
Yeah. And there's different medications we can use for pain from it.
Yeah.
Unfortunately, there is not a medication that has return sensation yet that we know of. There are different other things, like, for example, I think I mentioned B12 before. If B12 is low, that can also be contributing to it. In addition to your thyroid can be part of it, and as well as some other things. Some things that are over the counter that are really helpful are menthol 2% gel. The brand name is Mineral Ice, and you're supposed to apply that twice a day. Just don't touch your eyes afterwards. not good. But that can also be used for like sore muscles and things like that. But Dr. Tom Smith out of our palliative care department has shown some benefit from that. In addition to another supplement that's been studied a little bit more in gynecologic cancers, but and also a lot more in diabetes, is actually something called alpha lipoic acid. And that's 600 milligrams once a day. And as long as that doesn't really interfere with anything else, it usually doesn't. The only thing is if you already run low blood sugar, it could hypothetically bring it a little lower. And sometimes people will say they get some benefit from that. And then there's some prescription medications as well that sometimes might be helpful. Neuropathy does tend to be more of a burden at night. So putting the gel on at night can be helpful as well, because you are providing a new sensation to the areas that have neuropathy, and that can help in and of itself. We also have to take it usually a step further and look at preventing falls. See, I said it twice during this lecture. And making sure that it's not impacting someone's balance and putting them at a greater risk for falls. It's also important, if you don't have sensation in your feet, especially, to be checking your feet every day, whether it's pulling it up and looking or getting one of those mirrors like the customs agents use around the car to look at the bottom of your feet to make sure there's not, a staple or something like that in there. We were comparing war stories. Like, we've found things in people's feet before, or in their shoe that they didn't know was there, and making sure you follow regularly with a foot doctor or podiatrist as well. So,
and it's another example of a reason to see therapy.
Yeah.
Is because it's definitely an area we work within.
Yeah, and balance, especially in trying to get stronger, and compensatory techniques too.
And whether you need a walker, and so that it's the right size and height for you, that you don't just show up with the walker that you found in your garage. That might have happened once or twice. And it's either way too tall or way too small. But also we do, soft tissue, we do massage, I think balance strengthening works great with neuropathy. In the hands, we do taping. Feet, we can tape.
Yeah. Fine motor
exercises, coordination.
Yeah, I think there's some.
Yeah,
Okay,
I know.
we could go on for a really long time. I want to thank you all so much. Real quick.
I'm sorry to interrupt. I'm an occupational therapist. I certainly don't have a cancer specialty, but I had a patient with neuropathy and infrared light. She got return sensation. I don't know if it matters if it's a different cause of the neuropathy.
It depends on the type of neuropathy, and it depends on different components of it, but it is another one of those techniques you can use. It's just it hasn't shown to be impactful for everyone. What we know a lot of times with it is right now, what piece of therapy works for each person seems to vary still quite a bit. So I'm not saying it didn't work by any means, but I'm just saying it's not like the fixer-all for everybody with this. Yeah.
So remember, it is your journey, and everybody is different. They're in a different vehicle with different co-pilots. I want to thank you all so much, because this is so enlightening. We will do a webinar. That'll be something we will share. Thank you so much. And I would like to welcome Dr. Angela Smith to come on up to the stage.
If you could just drop your mics in the back.
Awesome.
Oh, she's going to be up here.
Yeah.
Thank you.
One of the things I think is so important is decisions made without me that are about me aren't right. And we were just talking now about adding quality to the quantity of life. When doctors, they know how to save you, they don't always know how to save the good things. So often I've heard, they saved my life, but they took away some of the best parts. And we'll talk more about that throughout the rest of our time. But this idea of patient-reported outcomes is a relatively new trend. And I'm really thrilled to say that was what started our very first summit. We worked with Dr. Angela Smith, who is from the University of North Carolina, where she is a professor of medicine and the director of urologic oncology at the Lineberger Comprehensive Cancer Center. And I am going to turn it over to Dr. Smith and remind everyone that we are always looking for more people to be Beacon Research patient advocates. So thank you. Come on up, Angie.
Thank you. Thanks, Stephanie. I didn't put that together, and I have a few pictures in here. We were making fun of myself that I tend to not take pictures and do a better job of that. But one of the pictures I think I have in here is from one of the first summits. So I'm excited to share that with everyone. As Stephanie said, I'm a urologist, and I'm also a researcher. I'm also a daughter of a father with bladder cancer, non-invasive, and he is in remission and doing well. So I wear many hats, and my grandfather actually had invasive bladder cancer, so his father, and he passed away of the disease. He was treated decades ago with really gemcitabine cisplatin. Well, it was sort of the cisplatin-based chemotherapy. So there hadn't been a lot of changes, as Stephanie said, until relatively recently. So it's exciting to go into this field and see what has occurred in at least the time span when I've been in training and now on faculty. So very briefly, I'm going to try to go through this relatively quickly, so maybe there's some time for a few questions at the end. But what I wanted to cover are three things, and I talked to Stephanie about what would be best. The first is, what is patient advocacy and research? That may be new for many people in the room, but it's something that you shouldn't be intimidated about. Every single person in this room is well qualified to do this. I really want you to take that away. The second is history. History is important, and I'm going to share sort of the history of how this got started in Beacon. And I will say it's really cutting edge in all of medicine. So Beacon is like carving the path for other types of diseases, not just cancer, certainly not just bladder cancer, but other things as well. And I'll end very briefly with the how and the why to get involved. So as I mentioned, patient advocacy comes in many forms. You will hear about this during the summit. I'm going to be talking about the puzzle piece of research advocacy. And you can see it's in the middle. I didn't make this slide or this figure, but I like it because it's in the middle. Because research really touches every piece of the advocacy in some form or another. Because in the end, what do we want? A cure. And how do we get there? It's through research. So I would say all of these things touch upon it. I like this quote: patient engagement is the blockbuster drug of the century. It's really odd to me when when you really look at it, it's like, how were patients not involved in the research we did in the past? It just doesn't make any sense. But not that long ago, years ago, not even a decade ago, it just wasn't a thing. And for many types of research still today, patients are not involved in the research itself other than being the participants in the study. And there's problems with that because some of the outcomes that are selected, the way that we feed back the results, if we don't have your opinions about your perceptions, like the way that you want to receive that information and what we're studying, then we're not doing a good job. So patient-centered outcomes research is sort of a subset of a type of research where patient experience is really, really important. And at the center here, it's about the questions and outcomes that are important to patients and caregivers. And so that's outcomes that matter. And that, more than anything, everyone in this room, it's what matters to you. Not necessarily the researcher, not necessarily the doctor, it's the patients. Doctors try to figure that out by listening in the clinic, but in the end, they're not a patient. So that's why this is important. Stakeholder perspectives. So patients themselves, caregivers, that's a stakeholder for sure. You can see other stakeholders too. There's nurses, there's so many parts of the care team. Their perspectives matter too. So we want to really think through all of that. Also, payers, because some of these new medications cost a lot of money. So you really have to get all of that on board. And diversity in opinions and thoughts. So really getting a sense of the perspective, not just of one type of patient, but many. So At the heart of all of this is something called comparative effectiveness research. And really all that is a fancy word to say that you're comparing one thing against another thing. And as a patient, that's often what you have to do, right? You come to the office, choices are provided, I hope, and then you have to make a decision based on the best available evidence. But sometimes that evidence doesn't exist. And when it doesn't exist, then that becomes really hard to make those decisions. So it's really understanding what's the best treatment for the right patient at the right time. And that answer is going to be different for all of those different variables. And you have to think about benefits and harms in so many other contexts, including quality of life. So that's where patient engagement and research, I think, really sort of paves the way for this. I have a windy road here because patient engagement and research isn't just a one-stop shop. It should be done throughout the entire research process. And so what I mean by that is that there are really three general time points of research. There's preparatory, execution, and translational. And the preparatory phase is really when you're setting the agenda. So that's really the research question. Why are you asking that question? Why is it important? We know there's only a limited amount of funding dollars out there, so we want to fund things that matter. Otherwise, we'd fund everything, but we can't do that. So it has to be something that matters. We have to prioritize the topics we research and make sure the questions are relevant to our patients. The second is the execution phase. That's when the question's been asked, it's been selected, and now you're designing the study itself. You're recruiting patients into the study, you're collecting the data. What data are you collecting? That's part of the design. And then you're analyzing the results. And then finally, let's see if I can go back. Uh-oh, it just keeps going forward. How do I go back? That's what I'm pressing. Oh, there we go. Okay. Maybe my thumb's too heavy. Then the third is the translational phase. So that's the third of the three phases. So it's really all well and good if you have a really good study, you have great results, you want to share it. But what if no one knows about it? It's surprising how much evidence is out there that's not used. I was just talking to Karen about sometimes like the evidence that we know exists. You might go to a physician and it happens, and they don't offer something that is level 1 evidence. Like we should be offering it, right? So disseminating results are critical because you can have great results, but if not, right people know it. We're not doing our job as researchers. So whether it's media, patient education, provider education, support networks, all those things matter a great deal. And then I say, what if all of those phases, patients were at the center of it? Well, that's the question we asked a long time ago. And we thought about that question, and then years later, here we are, and it's really exciting because the first summit was much smaller. It's so exciting. The question where how many of you are new, like so many hands were raised. It was exciting to me to see that. So it's story time. Everyone loves a good story, and it was fun for me to do these slides because it made me reflect on so much time and so much, relationship building and all of that. So we started at the start. We thought, well, we could do a lot of different things, but what if we just started at like, what are the research questions we should be asking in bladder cancer? And so that's what we did. And we wanted to engage patients. We had already almost like the foundation, because Beacon has done a great job of bringing patient advocates together in general. So we already had sort of the network, we had the think tank. So what if we engaged those patients nationally and asked them about research questions and help prioritize that? So that's what we did. And I'm going to do this kind of briefly, but this was the first, it was sort of a study that was conducted. It was funded by the Patient-Centered Outcomes Research Institute, so PCORI, which is a really large funding body. It's supported by Congress. And in these patient engagement awards, you can choose different things, but our choice was to create engagement within Beacon. And so the first was to create this patient survey network, which still exists today. We used Inspire. I'm sure, put your hands up if you've ever been on Inspire. Yeah, it's like, yeah, and if you haven't, you might want to investigate it. It's a really great forum to share your experience and learn information, et cetera. But we went there, we did webinars Beacon always loves a good webinar. I love the end. You're like, let's do a webinar at the last session. Careful. She might ask you to do a webinar if you do too well. But I love it because they work really well and they're durable content for patients. So I share a lot of the webinars with my patients. We sent out brochures. We went to Twitter. We did everything we could to recruit. And then we wanted to generate research questions. So we did something called a modified Delphi method. But all that really means, it's a fancy word for saying, we said, okay, here's some general questions. And then we asked people at the think tank, patients and researchers, and because the think tank's a nice amalgam of different stakeholders. And we said which ones are most important and then rank them. So then you start seeing some of these questions are really rising to the top. Some are less important, at least to the greater bladder cancer community. And then this is one of the first pictures. This is the first picture, actually. This is from the think tank. And I always show this picture when I show it to you because what I know that you probably don't know. Maybe there might have been a few people in this room who were at this meeting, but on the left hand, there was like an L so you can see it. On the left hand, like every single person over there were like urologists or doctors, and everybody on the other side of the room were patients, and I didn't have assigned seating. So it's just so different. We hadn't really done this before. And so there's some challenges because researchers and physicians, they have like a language, and I don't fault anybody for that. You grow up in that language, but it's not the same language as patients often. So I felt like a translator sometimes. And so that's what I felt like at the beginning, but I feel like I don't have to do that as much anymore because we've made a lot of headway. The second was we took that discussion, we decided on the questions to seed to these patients online. We sent it to this new patient survey network, asked them to rank questions by disease stage, because the questions would be different. That makes sense, right? Based on the disease stage. Added free text questions in case they had other things. We convened some calls. We started with only 354 respondents. We went over 1,000. We're over like 1,300 now. We continue to kind of keep around that number. So I'll give you a little more information. This is not to belabor data, so I'm going to run through these slides quickly. But what I want to show is for non-muscle invasive bladder cancer, the far left, that's the most frequently ranked high question. And you can see the top two was decision-making for bladder removal, which in bladder cancer speak, those are the patients who have the higher risk type, usually, okay? The ones that have to make that decision between trying another bladder conserving therapy or having their bladder removed is a really hard choice, very difficult. And the second is treatments for BCG when BCG fails to work. And those two are very much similar, okay? They're almost the same thing in many cases. So we knew that was the number one question, at least in our patient survey network. For muscle invasive bladder cancer, it was selection for chemotherapy and understanding the differences between cystectomy versus chemoradiation, which is another form of bladder preservation for muscle invasive disease. For metastatic bladder cancer, it was comparing the effectiveness of new treatments. And even today, there's some new therapies that were just highlighted recently at a conference. We're going to be continually looking at this. What's the difference, and which one does a patient want to select based on their particular preferences and their quality of life, the importance of quality of life, because there's certain symptoms that are more important to others than, and so I always ask that my very first intake is like, what matters to you? I need to know that. We need to begin with that, and then we go from there. And then the last, but certainly not least, is disseminating the research questions. That's where the story gets really good, guys. We did the patient survey network. Importantly, we sent it back out to the network so that they knew what the answers were. As anybody who's been in a clinical trial, it's very infrequent that researchers actually provide you back the actual results of the trial. That's not right. Okay, that's just not right. That's got to change. So that was important. Beacon, got it. And then funding agencies, and that's where a lot of the money is. Okay, so we fed it back to PCORI, to ARC, to NIH, et cetera. And lo and behold, PCORI, for the very first time ever, and I think it's the only time ever, they actually put out in their pragmatic funding announcement, and pragmatic funds are like millions of dollars. They're really, really, really big pots of money. They'll have like maybe 15 priority areas. And they don't just fund cancer, you have to understand. It's like dentistry, it's everything under the sun. But bladder cancer was listed, and that is huge. That's huge. And what did they list? Well, they listed that number one question in non-muscle invasive bladder cancer. So this is really exciting because once they put that on the priority area, they're more likely to fund it. And so that's where we really took off. We had 2 more engagement awards after the Patient Survey Network. We realized we needed to help patients feel more confident in being patient advocates. That's why I began with everybody in this room is capable of doing that. You do not need to be a research expert. You're not supposed to be that. What you're supposed to be is an expert in being a patient, and you all are, okay? And I very much really want to continue to iterate that. We don't expect you to know the research process. As researchers, we need to understand the patient experience. You can leave the research process to us, but we can teach you along the way. It's like co-learning, and that's fun, right? Like when we all learn from each other. So that led to PEER, Patient Empowerment and Engagement Research, and it was all about engaging patients, creating almost like a mentor system. And we've kind of created that. We have some individuals, some patient advocates who are seasoned. Karen is right here, and others who joined a little bit later, Lori, who I'm going to call. I'm sorry, I have to call on them. You'll see why in a minute. But it's never too early, never too late. Like just get involved. And there's a big community of patient advocates who are doing this work now, and caregivers as well. And then the third engagement award was a summit. And so we started with a summit in PEER, and then we continued with another summit with PIPE. I had to stay with the P theme. It's just a thing. Implementation, and we went from there. So these are the pictures of it might have been one of the first summits, I think. Yeah, I'm fairly certain that is. And what happened was we decided, what we'll do is we'll create some groups, like working groups on different patient questions. And I'm going to circle back to this because all of them ended up going somewhere. So we had these monthly working groups calls to kind of conceptualize what would this research look like. And the 3 groups talked about 3 things. One was about comparing bladder preservation to cystectomy for non-muscle invasive bladder cancer that recurs after BCG. Okay, that's one. A second one was on cystoscopy discomfort. How, if you go to 3 different urologists, you're going to get 3 different experiences on a cystoscopy. Whoever has gone to different or have the experience of different proceduralists, they're all different. I know that. My patients tell me too. I'm really careful in my cystoscopy skills. So I know that's what really piqued my interest. I always say I'm going to retire I'm going to be in the cysto suite. I love doing cystos. I pride myself on my anesthetic technique. Okay. I'm on it. My dad calls me all the time. He's like, did you get that study funded yet? I'm like, I'm working on it. And then the third was for muscle invasive bladder cancer, cystectomy versus chemoradiation. Okay. And these are questions I bet many of you are thinking yeah, these are questions you may have had to tackle yourself. All right. So what happened? Well, for the very first question, that's the one that the funding agency really wanted to fund. And so that actually created something called CYSTO. And essentially CYSTO is a study that's comparing the cystectomy versus bladder sparing therapy. And what I want to just point out here on AIM-1 is that first column. Alaina had mentioned patient-reported outcomes. These are all patient-reported outcomes. But importantly, patients chose these outcomes, okay? So you see quality of life, but look at the other things you see. Regretting your decision, financial toxicity. So is this causing you to go bankrupt? Some of these these things that we do. Sexual function, treatment preferences. And people really wanted to know how people came to their decision. So that influenced AIM-2. So all of this was incredibly steeped in patient opinion. And not only that, we had a patient advocate advisory board. And so I'm going to get to that in a minute. That's why I was picking on Karen and Lori, because they are part of our AAB, and there's several others who aren't here today but often come to summits you may not know. They created a video. And it was so great. I love this so much because we actually had in the budget, we're like, we could hire a couple actors. And they're like, no, no, they have to be real patients or it's like disgusting. And so I said, okay. And we did, and it was such a great video. In fact, the videographer, they're like, they did so much better than actors. I was like, well, I'm telling you, they run the show and they were right. And that was it. And so a lot of, so I encourage you, if you want to just Google Cisto, CISTO, comparing intravesical therapy and surgery, that video is accessible to all and it's a great video. And they talk about their experiences. And importantly, the study organization is a little different than a study because you see, okay, you have clinical coordinating center, data coordinating centers, the statisticians, all that stuff. But we have a stakeholder coordinating center. And guess what we have? An advocate advisory board. We meet every single month. We've talked about design, figuring out how we do the questionnaires, how we are thinking through the dissemination of the results because we're almost at the end of the study. We're at 555. Our accrual goal is 572. So that's like the newest thing up as of like an hour ago. I was checking on our numbers. And we're going to be finishing December 31st. So it has been a labor of love to get that many patient participants for a relatively rare form of bladder cancer. So I'm very excited for that, but we couldn't have done it without our patient and caregiver advocates. This is a picture. This is me making fun of myself for never taking pictures. So I scrounged this up, and this was from our annual meeting. And there are some patients here, I swear. Like there's some who are standing, there's some who are in the Zoom screen. But this is when everyone comes together, researchers, advocates, our external advisory board, so people who create guidelines. We have everybody, all stakeholder at the table so that we know when our results come out, they're going to get out there, okay? TURBT, get the facts. So this is in just a couple minutes, I just want to share, I'm actually just going to brag. This is what our AAB did, okay? Our AAB not only did things for the study, but they did it to help all patients in the future. They noticed that we didn't have a lot of things about TURBT, but there are a lot of questions about it. So this is what came out of our partnership, with Beacon, with our patient advocates, et cetera. We have a TURBT expert explanation that was reviewed by our AAB. Yair Lotan, who is a urologist at UT Southwestern on our external advisory board, helped drafted that. That's sort of like the physician's view, but then make sure that we can all read it, And then the TURBT treatment talk webinar. So Lori participated in that. Thank you, Lori. And that's durable content. And I actually have a little smart phrase I give patients for that. And then what I actually use the most of is this tip sheet on non-muscle invasive bladder cancer that returns after BCG. It's so good. It's actually 4 pages because there's a lot of information. It's very confusing, and we don't have any evidence. That's why Cisto exists. Okay, so I think to me that's the most important one because that's the question I get the most from my patients. So I'm grateful because our AB did that. Okay, they did that. So what's that influence? Well, we have funding. So Cisto was an $8.5 million grant from PCORI. Can you believe it? Which is huge. We have Cisto Discomfort. That is a grant in progress. And then Crocus, we picked that because it's the color orange. Stephanie, I wanted you to know that. It's comparing cystectomy versus chemoradiation for muscle-invasive bladder. So these are all the working groups that came from the Leadership Summit many years ago. And we have patient representation in various ways. Grant review, CDMRP. Put your hands up if you review for CDMRP. Karen? Oh, good. Lori. Excellent. All right. See, I told you I was bragging on them. They're pretty awesome. I know. That's why I put their hand up. Okay. Yes, please do that. And industry, there's pharmaceutical advisory boards. Has anyone ever done that? Oh, wow. Okay, great. Good. I'm doing that too. See, look at you. See, there's just a lot of opportunity if you're interested. Preclinical trials and then clinical trials committee. So I heard Daryl, you're doing SWOG now. Rick Bangs used to do that, and he's like passing the torch, so to speak. So there's just a lot of opportunities there. Disseminating to other sites. A lot of GU cancers and cancers in general actually looked to bladder cancer for the model because we were the first to do this. So it's pretty cool. I love you said we're trending. We're definitely trending. And then the potential value for patients is incredible. You can, I hope you could see that in this. these are just two general quotes I got from patient advocates in the AAB, but I love that they said, you know, it transforms vulnerability into strength, uncertainty into hope, isolation into unity. And then the other, a way to use my personal experience with bladder cancer to inform decision making for other patients. It's just, I think what they get out of it, from what I have heard, is a tremendous amount. So it's just, I think, at least from a lot of patient advocates I've spoken to at the beginning, it can be intimidating, but I don't want it to be. It's really, you know, when you join a team, you're well respected and well valued for the experience you bring as a patient. And so how to get involved is the last just 1 to 2 slides, is just learn about it, be open to it, take a risk, just try it. And to try to become a research patient advocate, just dip your toe into the water in some way. If one of these kind of jump out to you, let Stephanie know, or the Beacon team, because they often end up being the matchmaker in a lot of these processes. If you want to be one of those like fly on the wall, like let me just like watch for a while. I can't remember what that's called on Twitter when you're lurking, you're a lurker. Then fine. Just join the patient survey network and you can be involved in that way. So I put QR codes, which thank you, Stephanie just like gave you the warm up of how to do this. But these are 3 QR codes you can use. Engaging clinical trials, there's a really great webinar from the patient perspective on what that looks like. Joining the Beacon Patient Survey Network, that's an really easy survey where you just enter your information. And then engaging with pharma as a patient is the last one. So I know we're almost at time, but I'm a talker, you can tell. So I'm sorry about that, but I appreciate the time and take any questions with the last few minutes we have, and we can talk a little bit at the break too.
Any questions? We're not going to have a whole lot of time. Dr. Smith is going to hang around for a little bit, so speak loudly.
Okay, let's speak loudly. You mentioned that Cisco received an $8.5 million grant. That's great. When would the results of the Sisto study be finished?
Yeah, great question. So we are going to close the trial December 31st, likely unless we hit 572 before then, but in any case, in the next couple months. And because our primary outcome is 12-month physical quality of life, but we're going to be looking at other items as well, like cancer-specific survival, all of those things. We won't have the results till a year after that. So basically December of next year, we'll have those results. And we intend to share with Beacon, with patients, all of that. In fact, our AAB is already, that was our last AAB meeting this past week, was how we're gonna give it to the patient community. We're already excited to think about that. So thank you for that question.
Great, thank you very much.
Yeah.
And also thank you for a great presentation.
Yes, of course, happy to.
So we'll definitely talk more about how you can become a Beacon Research Patient Advocate. I've got a really simple thing for you to do. You just give me information on the website. I keep that so when opportunities come, I try to match the best person to the particular opportunity, including things like writing recommendations for people to be CDMRP reviewers for these huge $1 million grants that are funded by congressionally mandated Department of Defense research dollars. And these are significant things that also have some kind of a direct impact on our service members in the military or veterans. But Dr. Smith, thank you. You are just the best ever, because this is something that has been a passion of Dr. Smith. She works very closely with Dr. John Gore at the state of Washington. Dr. Smith is in North Carolina. Dr. Gore is in Seattle. They can't be any further
coast to
apart.
Coast to coast.
But they are one mind when it comes to it's the patient. It's all about the patient. It should always be about the patient. Beacon believes that. Beacon is thrilled that Dr. Smith and Dr. Gore and the rest of the folks are very engaged with us. And we thank you for coming all the way down for the day. I know you have a flight to catch after this, but